Well, let's get started. Welcome, everybody. My name is Elizabeth Aloni, and I'm with Schneps Media. We're the largest local media outlet in New York City with over 70 publications across New York, including Manhattan, Queens, the Bronx, Brooklyn, Westchester, and Long Island. We reach people every day and weekly and monthly with our different publications via print, web, email, and as you see, webinar. So today we're very fortunate to have three very special doctors with us today to discuss screening and cancer treatment during the time of the COVID-19 crisis, providing outpatient options. I want to get started by introducing each of our esteemed doctors. First, I'm going to tell you a little about Dr. Azizi. She's a medical oncologist at Vantage Physicians. She's a board-certified medical oncologist and hematologist. She did her residency and fellowship at Beth Israel Medical Center in New York City, and she's currently on staff with Advantage Physicians in Forest Hills, New York. Dr. Gliedman is medical director in radiation oncology at Vantage Medical Group, and he has extensive experience in managing cancer of the breast, prostate, lung, central nervous system, and gastrointestinal tract, as well as gynecologic cancers. He has expertise in cranial and body stereotactic radiosurgery. He's frequently named to lists of top doctors and has been named, for example, as New York Magazine 2019 Best Doctors. Last but certainly not least, we have Dr. John Kehoe. He's a medical director and breast surgeon at the Dr. John Kehoe Breast Center. Dr. Kehoe's first position was at Maimonides Medical Center in Brooklyn, where he had a brief stint as an academic and research surgical oncologist. He abandoned this around 1990 and went into the private practice of surgery as a surgical oncologist and general surgeon in both Manhattan and Brooklyn. Does this sound familiar, Dr. Kehoe?
Yes, it does.
A few years later, he focused exclusively on breast cancer. He then conceived and founded an innovative breast center facility in Brooklyn that's provided comprehensive breast medical care from screening and diagnosis to breast cancer treatment. He's maintained this facility in his practice since then and is now partnering with others to take this concept into other venues. He's been an attending surgeon at Beth Israel Medical Center, Methodist Hospital, and Staten Island University. So I want to say a big warm welcome to these three prestigious doctors who are going to kind of walk us through some of these important things. Doctors, you know, time of COVID is very scary for all people. But those that are suffering from cancer or fear that they're suffering from cancer have other predicaments and concerns in weighing their cancer care and caring for themselves to stay healthy during COVID. So as a first start, Dr. Gliedman, can you tell us, are you treating patients that have cancer currently during the COVID-19 crisis?
Yes, we are. By the nature of what we do in radiation therapy, radiation therapy is given in a course of treatment. It's not a single treatment. It's not like an operation that you can schedule, complete it in 1 hour or 5 hours and you're done. A course of radiation can continue for anywhere from 2 weeks up to 8 or 9 weeks. So you can imagine we have groups of patients on treatment who started before the crisis even began, or at the very beginning in early March or mid-March when we began to understand something bad was coming. And then people who we had to make decisions about whether to start their treatment in the middle of all this. So it did pose quite a problem. Now, our priority was patients that were already getting their cancer treatment. You really don't want to interrupt their treatment. It will compromise how well it works. So our priority was to treat the patients that had already started, and you can imagine if someone's coming for 2 months, some people started before all this was really coming to everyone's attention and are just finishing now, and they kind of weathered through the whole thing. So we had to take care of them. And then the biggest decision was, what do we do with new patients who are sent to us, patients who had had surgery before this started and needed to get radiation therapy. So we were put in a position of basically like triage, deciding how and when to start cancer treatment, which was foreign to most of us. I mean, I've been doing this for 30 years, and The mantra is diagnose it early and treat it early, and there's no reason to ever delay. But in point of fact, there are some cancers that are very aggressive and need to be addressed right away. And there are other cancers that can wait, sometimes weeks or if not even months. So we really had to move to a mindset of addressing the patients who are most urgent and really couldn't wait at all, certainly couldn't wait until this wave of the crisis was subsiding. And then some of the patients put off on a holding pattern until we could start their treatment. So that was really where we had to balance the need to treat a person's cancer versus the risk of bringing them out into the outside of their homes after the stay-at-home order. And it's not, and if you think about it, the patients who often get cancer tend to be older, tend to have other conditions, are all the same risk factors for COVID-19 and the complications from it. So we really had to balance this in our minds. So
that's more complicated, obviously.
Yeah, it became very complicated, but we continued to treat the patients that were already on treatment, and some patients started, and the patients that we could put off, we put off, and actually are kind of starting more patients recently in the past week or two.
I think, to highlight something that you said was, in certain cancers, it's critical for care to continue. And
Right.
that, not continuing is even causes more damage than the fear of COVID. And that, working with your doctor, you really need to see where you are and take your cancer treatment very, very seriously. And not just assume because of COVID, you're not going to take your treatment.
Right.
That's an important point. Dr. Azizi, as a doctor who specializes in the treatment of cancer, what kind of concerns are your patients sharing with you during this COVID crisis?
Well, of course, the whole idea is that it's this competing risk of COVID versus the risk of the malignancy continuing to grow and progress. And so, as it is for us a hard decision to make as to whether proceed with treatment and risk having patients be infected by the virus, the patients have very similar concerns. A lot of them want to continue treatment, but at the same time are concerned about exposure coming into the office, getting on the bus and the subways, and so on and so forth. So very early on, we decided to really implement as much social distancing and making sure that people were being screened before they actually came into the office, and so on and so forth, in order to minimize the risk of COVID-19 and continue treatment.
So how are you doing that? How are you able to assess people? Was this through telemedicine?
We're doing a lot of telemedicine, yes. In patients who we feel can actually stay home and just need a visit, virtual visit, we have set aside certain hours of the day where we do that, and we can discuss whatever complaints the patients have and discuss testing in the future or sooner if necessary. We also do telephonic visits where patients who don't have a computer or unable to do a Zoom virtual visit like this one, I talk to them over the phone and make sure they're doing okay. And then we do have patients who come in, obviously, for chemotherapy, for injections, and for regular visits, because it is absolutely necessary for them to come in.
Well, I certainly want to talk about the protocols, but let me just first jump over to Dr. Kehoe, because, dealing with diagnostics and surgery, it's a little bit different than treatment. What about a patient who feels a lump and is afraid? What do you recommend to them during this time of COVID?
Well, I guess it depends on the context and how they're coming in. As surgeons, we have a sort of a long run-up to the time that we operate, and then you're either operating or you're not operating. If you have a lump that you can take care of in the office before the COVID pause came upon us, we try to do the biopsy in the office as much as possible. And then proceed from there. We do a type of clinical staging beforehand. If it turns out to be malignant, we do a type of clinical staging and then decide upon surgery. But as a surgeon, you're either operating or you're not. We have more of a run-up coming into surgery than we have issues afterwards, or post-operative issues, and sometimes they're re-excisions. But everything really centers on the operation, the definitive operation that you do for the cancer. And
Where
what
are
happened
you now? Where are you now with surgeries? Where, what have been the protocols around surgeries right now and over the last, and has that changed over the last few weeks?
highly complicated, and it depends on where we are in the COVID pause. Obviously, everyone around the end of March, at least in the New York area, stopped operating. All the operating facilities were used for the COVID patients. Either elective or non-urgent surgery was put off for the most part. Some people were able to operate. I didn't operate for 5 or 6 weeks.
Wow.
I had, before that, approximately a dozen patients who had cancer diagnoses and were going in for the definitive treatment that we had sort of lined up for 3 weeks straight. And those people all got delayed. They're being taken care of now. As the pause went on and as the crisis went on, things started to loosen up. Where I started operating again in May, which is 6 weeks afterwards. Our issue was, what do we do with those people who have a cancer diagnosis, are nervous about it, and what can we do in the interim? And there was some thought about possibly putting some of them on medication to tide them over, depending on how long the pause went on or how long we were kept out of the operating room. We ended up not doing this. I think there was some resistance. I think if it went on for another month or so, we would have been more inclined to do it, but I ended up not putting any of them on any anti-estrogen medication.
Okay. And what, if someone is concerned, what goes into determining if it's worth the risk to come into the office? Are there hereditary factors? Are there past health factors that come into play? How do you determine if someone should wait a little bit longer or they should see you?
Well, again, I guess pre-COVID, that was really not much of a consideration at all. You
Right.
usually made the arrangement with the patient as to how quickly they wanted to get into treatment or not. There's also, as I say, can be a fairly long run-up to treatment. You're doing tests beforehand, you're getting approval for the surgery, you're putting them through clearances, et cetera, et cetera. So it really depends. What happened for the most part is that most patients didn't want to come in. They didn't want to go to the hospital. They want to go to any place that was public. And they sort of self-selected their way out of the surgery in some cases. I have a patient right now that will not, she's at high risk for COVID and she doesn't want to go anywhere because she's at high risk. And in a way, she's right. She would have a greater danger of getting COVID and dying from that than she would of the cancer that I was going to treat. But it does delay the treatment.
Well, that's a really good point. And how each patient is so individualized in terms of the type of cancer they have, the aggressiveness of the cancer, and then also determining their risk factor for COVID. But, Dr. Gliedman, let's say a patient decides that they want to move forward or they need to move forward with their treatment. What are some of the protocols that you have in place to keep people safe from COVID, or as safe as possible, I should say?
Right. So a lot of the things that we've all been doing, we do in the office, meaning social distancing, wearing a face mask. We've tried to spread out the schedule such that we wouldn't have more than one person in the waiting room. Patients were pre-screened ahead of time, like Dr. Aziz alluded to, in terms of any symptoms they might be having. But if they were already committed to and on treatment, again, we keep the number of patients that would be here at any one time at a minimum. The office and all the areas are disinfected daily. The staff wear face covering, the patients wear face covering. So all the same things that we're all doing everywhere, we just make sure we do it here. Early on in the crisis, we, like other offices, we were considered essential, so obviously we had to keep functioning, but as much as possible, we moved staff out to that could work from home. So we, in a sense, worked on a skeleton staff, just having the absolute necessary people here instead of 2 or 3 receptionists. If we could minimize the number of staff that were needed to take care of patients, we would do so. So all the same things that we're all doing, that all kind of are second nature now. Early on, we had to learn about and think about and change our protocols. And it was really just like for everyone else, we had to very quickly adapt and do things differently.
Yeah, and for you, the stakes are so high that there was no room for to be lackadaisical on it. It really, and also as doctors, I mean, some of this protocol, I mean, isn't it very similar to protocols that you follow anyway, you know, with having to have sterilization and wiping down the room after each patient. And there's that potential for infection even before COVID.
Right, absolutely. We're all trained to take universal precautions. We all are somewhat OCD in terms of washing our hands. So a lot of this, yes, was second nature.
That's good. I mean, that's certainly good to know. Dr. Kehoe, you specialize in diagnostics and surgery. How are your protocols for safety? Are they the same? Are they different? Are there some things that I mean, obviously if you have to come into a hospital, there's more factors involved than in an office. So what are the protocols that, you know, or additional protocols? Because again, with surgery, that's, you know, a sterile environment, always has been. But what additional protocols have you been doing or putting into?
I'll sort of divide the diagnostic from the surgical. Obviously, we did the same thing that Paul was talking about in terms of keeping the office clean and having the cleaning service come in midday and going through these sort of elaborate anti-COVID sterilizations in the middle of the night with people in hazmat suits to keep the place clean. Obviously, there are cleanliness protocols that we have to go through. The machines are wiped down regularly. I think that we just became hypersensitive and hyper aware of it. And then as the crisis, you know, continued, you know, and, you know, for the office work, we went to masks, you know, gloves being used for everything. We weren't really used to that. I've been in a surgical mask all my life. Towards the end of this crisis, I had to come back and wear a surgical mask all day, and I found it the most annoying thing in the world to do. I really hate them now. I haven't thought about them for years and just sort of routinely put them on. So as far as the office is concerned, that was done. And same thing, we limited the number of people that could come in. We tried to keep sort of non-essential radiological studies to a minimum. We tried to screen as well as we could to only bring in urgent cases or cases that needed immediate attention. As far as the surgical protocols go, obviously it's pretty disciplined there for the most part. I mean, we are usually gowned and gloved, but there's a whole lot of activity outside of the operating room in any surgical center. And I work at an ambulatory surgery center. Part of the reason I work at an ambulatory surgery center is that the infection rate is so much lower. You don't have the same traffic going through an ambulatory surgery center, private freestanding ambulatory surgery center, that you do in a hospital. So in a way, that was sort of eliminated. I think people took were pleased with the fact that we weren't going into a hospital or into the hospital environment. So I guess it just varied, and it varied during the course. I mean, this thing, it's hard to imagine, this thing just hit about 6 or 7 weeks ago, and it feels like we've been through an epoch of change and an understanding of what's going on with the virus and what we need to do. As far as the surgery was concerned, in terms of operating, that was pretty much determined by forces outside of us. We were basically told not to do anything but the most urgent operations, and they weren't available in either hospitals or ambulatory surgery centers. So our hands were kind of tied, didn't have to do much there except just wait around and hope the time would come when we could do what we needed to do.
Right, right. Well, it's a very good point that you make about the ambulatory service centers, where you can still be able to get the surgical care without having to necessarily go through a big hospital. And be able to limit your exposure there. So that's a tremendous benefit for sure. Dr. Aziz, I wanted to get back about patients outside of patient care outside of treatment, and back to talking a little bit about the telemedicine and more specifically, how does that work? How does that work both from a Zooming perspective, like we're doing, or on the phone for people who may be at higher risk and they're just not used to using technology, and also how does that how do you deal with the privacy concerns?
Well, in terms of privacy, I mean, all the Zoom visits take place in my office and there's no one else around. In terms of our conversation and HIPAA, issues. We have a whole team of technicians and computer specialists who work with the patients prior to the day of the visit in order to help them set up to be on. The patients have to be on the portal, on the Advantage Care portal, in order to have a virtual visit. And then once they've done that, we help them learn how to initiate the actual visit. And my assistant kind of cues everyone up so that as soon as their visit the visit time is up, that's when I get on and everybody's there and we start the conversation. It was, I mean, obviously it was a difficult transition for everyone. We had to get the equipment and so on and so forth. But we did find that, as was said previously, a lot of our patients are elderly and not everyone is able to negotiate the computer and the buttons and so on and so forth. So we decided that we would add the telephonic visits for those people who either didn't have access to a computer or weren't able to initiate a virtual visit. And so we now also have these telephonic visits where we can review medications and so on and so forth.
So it sounds like you provide your patients with almost a training, before they have to, get in touch with
Yep.
you, so that they can feel confident and set up. And because obviously, these conversations are not easy to have even in person. So to be so far away from their doctor, must create other emotional concerns. So being able to walk them through the process of how this goes would be a very important thing.
Yeah.
To be able to do.
Yep.
Yeah. Dr. Gliedman, what about you? I mean, have you anything else you can add about telemedicine? And perhaps, is this something that we're looking at that will continue into the future? Do you see this as something, even if we're past, let's say, the worst of this? Do you see that medicine moving towards telemedicine, that move continuing?
I mean, I think we were all forced to do everything this way in a very short time. And it was different than how we all trained as physicians and how we practice as physicians. I myself personally will be very happy to get back to all visits being in-person visits. I think there's so much more to be gained by that. Of course, there are the examination you have to do, the physical examinations. It's essential that you have an in-person visit. But even the visits that potentially could be addressed even after COVID by telephone or telemedicine, I think for the most part, I want to get back to medicine as usual. I don't know when that will be. And for now, what we've been doing as much as possible during the care and follow-up care, where it used to be in person, we would do it by phone or telemedicine. But there have been times when you have to bring some, especially patients that need to start their treatment, they need to come in for an in-person visit and be seen and be examined. So there are still patients that are kind of being proceeding as usual or as the old way. So
Well, look, I think
it's a hybrid right now.
Look, that's an important point, because I think, the thing to drive home too, that we touched upon, each of you have kind of touched upon, is, when it's critical, it's critical. And that patients really shouldn't be making that decision on their own just out of fear. And that speaking to their doctor is really the best way to know if, they're in a situation where they can wait it out, or they need to continue their care regularly, or is it somewhere in between? But, really driving home the importance of that. Dr. Kehoe, obviously diagnostics is a tough thing for telemedicine. Are there any applications for telemedicine in the diagnostic process?
Not really. I mean, it just depends on what you're doing, in the diagnosis. We not only do the radiology, but we also examine the patient. That's a very important part of what we do. And that's really hard to get that into a telemedicine motif. It has some value, I think, post-operatively. If someone's having a wound problem, they can send you a message and you can look at it and you can evaluate that. But that's been going on for a while with FaceTime and Skype and all the other things that have been out there. I think Paul's point about the fact that we've all had to adjust, doctors tend to be pretty rigid sometimes in terms of their schedules and their expectations, and this has thrown all of us off. None of us has seen anything like this in our career, where the whole assumption behind our practice and our methods of practice have been called into question, or at least disrupted. One of the things I found out about this is there were weaknesses in my office in terms of our ability to communicate with people. We, usually we communicate by telephone or by mail, but we didn't have any real system out there to send out messages to, to hundreds or thousands of patients to tell them what was going on in the office. Obviously, that's something we learned in that period of time, and we're now doing it. But I think it exposed both strengths and weaknesses, among the doctors. I think I sort of look at all this stuff. It's like having grand rounds on television. We've got all these doctors coming on and speaking and giving information, and they've all handled themselves pretty well. I think the major doctors, Dr. Fauci and Dr. Birx, have handled themselves beautifully, on the national stage. So I think it's, for us, it's a matter of having things changing. I think for the public, it's a glimpse into what we do, which is sometimes taken for granted or not really brought out in the open and discussed.
It's a really good point about how important it's been for doctors to be flexible, and that in some ways the silver lining is the learning of, what was missing link in the office. But certainly being able to make those changes. I mean, it is extraordinary that it's only been 7, 8, 9 weeks. And all of our lives have completely been changed. And, being able to set up these protocols and being able to do telemedicine and being able to advise patients to take the cancer seriously, not just COVID. We're reminded every single day on TV to remember that COVID is important, but, also we have to remind people that cancer is important. We have a question here that I think is quite pertinent, which is, am I at risk for getting breast cancer if I missed my mammo appointment? Is breast cancer aggressive, or can I wait another year? So what, who would like to take that question? But, yes, with mammos, we're told that, we really shouldn't miss them. And so where should one be around that? Do you want to take that, Dr. Azizi?
Yeah. It's an individual question, because some people have either a family history or a personal history of, for example, breast cancer, in which case it's probably more important to stay on schedule in terms of screening. And there are other people who are younger and don't have as much of a risk and don't have a family history. And in those circumstances, we have recommended that screening be put off for however number of months it takes to make it safe for people to come back again. But I think, generally speaking, a screening mammogram is not an urgent study. I wouldn't say during the height of the pandemic in New York City, I don't think I would recommend anyone to have a screening mammography unless there's a very, very good reason.
That's exactly what happened, by the way. Screening mammography has gone way down during this period of time. I think there's been a certain amount of diagnostic mammography that's gone on. But we, during what I call the COVID pause, I don't know how many radiology centers were really working at any sort of reasonable capacity. Obviously, there were other studies to do and other modalities to look at. But I guess the answer to the question is it depends. It depends on the cancer they develop, and you don't really know what kind of cancer they develop until you biopsy and find out what it is. So you can't really get a good grip on who's going to develop an aggressive cancer and who's going to develop a slow-growing indolent cancer. Obviously, if we could, it'd be a lot. We could triage the people in many different ways then.
So it's really a two-pronged thing. One is to take a look at, and when you're calling about your mammogram or speaking to your doctor is, talking about what are my risk factors, am I at high risk, and discuss that with your doctor. But then the other is, even still, we don't know what we don't know. And so, it's a good conversation with your doctor and with yourself to determine, the risk versus reward. What you mentioned something that, kind of hit me. I feel that there's been so much communication about the importance of mammograms, and, mammograms, people are so much more diligent about it and speaking about it. And you're saying about, how these have now dropped. How can we make sure that this isn't a trend, and that we make sure that people continue to take their mammogram seriously when we're in such a difficult time. You know, it would be a shame for there to lose momentum around this important diagnostic tool.
Yeah, no, I mean, it's obviously you've got to stay on top of the situation. We've gone back and traced the ones that got canceled in the latter part of March and throughout the month of April. There was a lot of self-selection in that. There were a lot of people that would not come in. I mentioned before about being able to communicate with large numbers of people. We do have a system here, but it's sort of based on a monthly situation. You know, who's supposed to come in this month and who's supposed to come in that month, and we were able to do a kind of mass communication setup that allows us to keep reminding them. And I think that's all you can do. You can, which we do anyway. I guess, you know, throughout the year, there are a lot of people that miss their appointments, and most radiology centers are on top of them, you know, to keep reminding them and sending out letters, et cetera. So I think this just sort of, it probably amplified the systems that we had in place to see to it that that people come in and do their appropriate diagnostic work and screening.
Can I just add to that? I think that's one advantage of working in a multidisciplinary setting, where if a patient, for whatever reason, doesn't end up seeing me and doesn't get their screening mammogram, they will be seeing their primary care doctor or some other provider within our system, and we all together make sure that we are keeping track of everybody's surveillance and screening. And the same is true for me with my colleagues. For example, radiation oncologists that I work with, we go back and forth. All of us make sure that patients are being screened and surveilled in a timely manner, so that if one of us misses it, then the other person picks it up.
The importance of the team.
Exactly.
No, we have an attendee who sounds coming from a place of fear, that you know, she feels hospitals are filled with COVID patients, and I don't want to get my chemo because I don't want to catch it. I'm afraid of going. And she wants to know, or he wants to know, you know, will my cancer come back if I wait until this is over? I mean, so there is an example of someone who's really, you know, dealing with the fear of what to do. What would your advice be, Dr. Gliedman?
I guess, I mean, it's really a question for Dr. Azizi since it was chemotherapy, but I think in general, without knowing the details of that person's problem, it's hard to answer. But I mean, again, they have to rely on their own oncologist who knows their case and knows, again, like I said in the beginning, we're triaging patients that really need to continue their treatment and really need to come in. We will emphasize that and try to get them to do that. And patients that can put it off, we'll counsel them on that it's okay to wait another 6 weeks, or it's okay to wait another 2 months. So they really, that any patient and that patient should rely on their own oncologist's advice, who knows their case best. So
don't just let your fear stop you. Make sure you speak to your doctor and make sure that you consult them.
Right, and you may be surprised. I mean, like I said in the beginning, we're all conditioned to diagnose and treat cancer as soon as possible. We've all been forced, even as doctors now, to think on a more granular level and realize that not every case is the same. And yes, there are cancers that, you know what, they can wait. Their treatment can be delayed a few weeks or a month or two, and it really isn't going to impact their well-being. So, you know, each case is different.
But it's not something that the patient should decide. It's something that
No.
should be brought to the doctor. No matter how scary it is, your doctor understands the fear and understands the risk and can give you a much, you know, guidance on your health.
Right.
Dr. Kehoe, does your facility have mammogram screening?
We're basically a diagnostic center, and most of the people come here with a problem. The problem is addressed in one way or the other. We obviously use radiological services here to help address that. The problems may never go away. They may stick around for a long period of time. Some of the people probably do edge into a kind of screening protocol. But for the most part, we don't invite screening mammography for the most part. It's a diagnostic center.
Okay. And most of the places when you, there are plenty of places to go to that can be, not having to enter an entire hospital to have a mammography.
I mean, most of this are freestanding. There's some that are associated with a hospital, private freestanding radiological centers, and then there are some associated with the hospitals.
So those are good options if people are afraid to go to the hospital. It's another option for them to still be able to get their mammography.
Yes, there are plenty of options out there not to put yourself into COVID land in a hospital, which I think is how most people look at it.
Yeah.
And I mean, it's sort of a double-edged sword. We all have a great deal of respect for what the hospital workers have done treating people, but they've been kind of stigmatized because they become COVID centers and whole wards are taken over by COVID patients, et cetera. Or hospitals become a COVID hospital and another hospital they're affiliated with is not. So I think that my sense is that most people I was dealing with were really reluctant to set foot in a hospital, unfortunately. And I think there are alternatives, to that, which is sort of the freestanding centers, ambulatory surgery centers, as opposed to a hospital operating room.
So again, it's talk to your doctor to be able to find ways around your fears if necessary, and there are things that you can do to mitigate the risk.
Elizabeth, we here at Advantage Care, we actually do have a radiology department in our building, and we do offer both screening and diagnostic radiology studies. I also want to say that over time, we've learned so much about the virus and how to avoid it. And I think the fear, as the number of infections drop in New York City, I think the fear is also smaller. I think we all know how to avoid it now, wearing masks, making sure we're washing our hands. So I think over time, it's become easier to go to the doctor's office or to a radiology department to get a CAT scan or a mammogram.
Yes, Governor Cuomo was talking about that the lowest rate of infection are nurses and doctors and first responders, because those people are using so much of the PPE and using so many of the protocols you're talking about that they've been able to keep themselves safe. So that was just recently, in one of the updates by the governor. What about colonoscopies? Can they wait like mammograms, or is it a similar feeling about that it's about, your risk and individual based on the person?
It's individual. If for the most part, there were no screening colonoscopies being done in the past several months, but in people who had alarming signs or symptoms, such as anemia or bleeding, those people were able to get a colonoscopy, not screening, but diagnostic.
Okay. We have a question from one of the attendees who says that they were diagnosed with prostate cancer, and my doctor said I don't need treatment right now and that I can wait. I need a second opinion. It's stressing me more than COVID. Now, I'm not asking for any second opinions on this Zoom. We are not giving medical opinions, but what can this attendee do to alleviate some of that fear?
Well, I mean, just in general, I would tend to agree with the statement. Prostate cancer is a slow-growing cancer, and even in non-COVID times, it's not the type of cancer that we rush into treating next week. It's something that, and in fact, many prostate cancer patients get what's called active surveillance. Their cancer is so small or so early. So again, every prostate cancer is very different. But of all the cancers we treat, prostate cancer is one of those that very easily can be delayed generally. If it's more aggressive, they can be put on hormonal medication, which is actually the preferred treatment in COVID or non-COVID times if it's an aggressive cancer. So I think that person probably got the right advice. And nowadays, in the age of telemedicine, it should be very easy to get another opinion if that person desires.
So good to know that you're not surprised with that diagnosis, and that certainly a second opinion, if that makes them feel more comfortable, is certainly the way to go.
Right.
Someone here asked that they're not comfortable with telehealth appointments, and they want to make an appointment for a mammo and be examined. Are doctors allowed to deny appointments? How are doctors managing, are doctors managing their caseload due to COVID?
It's really hard to turn a patient down in a lot of ways. I can't think of too many circumstances where we do that. There might be an insurance issue or some other issue or some timing issue. I don't know what advice to give people to say how hard to push or who to push or whatever. If you think you need something, I have a feeling that if a doctor perceives the need is great enough for them to come in, everyone will take the chance on the visit. I assume that's the case. On the other hand, you can see how that can be manipulated in certain ways.
So typically doctors are pretty, obviously doctors want to heal and they want to take care of their patients. And, that typically isn't the thing that stops people from getting mammograms.
Yeah, I mean, I think this whole thing is, I mean, I think every physician that I've talked to feels that their hands have been tied behind their back to a certain extent, that life has been put on pause and the medical professions that usually runs has been put on pause or, slow motion. I know I was anxious to get back. I couldn't do anything in the hospital, at all for various reasons. And I felt bad not seeing my patients and felt bad that they were nervous. There were a certain number of them that were still nervous and wanted to go ahead with their care. I mean, we took our time doing it and put in all the appropriate precautions. But it was good to get back to work in some capacity.
Mm-hmm. So an attendee was asking, are you concerned that people will die in a few years from not getting treated now for cancer out of fear? It's a very, serious question. I think it's something that we've been talking about, the importance.
That's a huge issue. I think that's kind of front and center. 600 doctors wrote Trump in the last couple of days saying, we have another emergency here with the people who are denied employment and denied medical care, and we need to address it. Who knows? I mean, the emergency room doctors have wondered where all the stroke and heart attack patients have gone. They don't see them in the emergency room to the same degree. I think in this country, about 150,000 cancer cases develop every month. I think you can look back and say over these 2 months, there are probably 300,000. You don't know how many of them got treated or got diagnosed. You don't know what the cancers were. I haven't seen these stats on it. But I think we all have a certain amount of unease about the fact that things aren't getting done that should get done.
Dr. Azizi, do you want to, thank you for that, Dr. Kehoe. Dr. Azizi or Dr. Gliedman, do you want to add to that?
Yeah, I agree. I think it's really difficult to predict what the effect of this whole situation will be in the future for some patients. We don't know, and we made a lot of decisions early on. For example, in lung cancer and patients who were getting immunotherapy, we decided that we would delay their treatment, extend the periods in between treatments because we thought that was safer and that would protect people from COVID. And we don't know what the impact of that will be in the future. Hopefully none. We think none, but hard to predict.
Yeah, I think for patients that are on treatment, we've all tried to do a very good job in triaging and continuing treatment for those patients who really needed it. In terms of patients who are undiagnosed or not found yet because they didn't have a screening colonoscopy or a PSA or a mammogram, we're concerned as doctors, but if, again, we all take a step back, it seems like it's been forever. It's only been since mid-March. So in the scope of things, missing your mammogram and rescheduling it 3 months later or getting your PSA 4 months later, a year from now probably won't make that much of a difference. I really don't believe it will. Of course, we're all concerned how much longer this will go on, but it does seem to be improving. So I think in terms of screened cancers, we'll catch up. At least that's my hope and my belief, that we'll see a dip, but we'll catch up as we move into the later part of this year and early part of next year.
Someone wanted to know, what is PSA?
Oh, PSA is prostate specific antigen. It's a screening test for prostate cancer. So it's like the male mammogram without pain.
There's not as many commercials.
Test, yeah.
A little less painful.
A lot less painful.
Well, I think, you really drive home the point that, when it comes to screening, a month or two is probably not going to be what you fear, but that just deciding on your own not to have cancer treatment is something that you would fear, and that it's incredibly important to make sure that you make those decisions, whether it's surgery or treatment, that you make those decisions, you know, with your doctor, as opposed to just letting your fear be in charge and make a decision that could adversely affect your health.
Right. I agree.
I have one more question here. We have a question about insurance, about what happens to someone who's getting treatment and now lost their jobs and doesn't have insurance. What's being done? Is there any support for that through these dollars that have been given to citizens and businesses? Dr. Gliedman, you just need to unmute.
In terms of our centers for radiation therapy, both during COVID and before COVID and after COVID, remember I said that a patient starts their treatment, it may last 2 weeks, 6 weeks, 8 weeks, or 9 weeks or more, and you can't interrupt that. And if there's a problem with insurance, we would never interrupt it. And that was the case last year, it's the case these months, and it will be the case going forward. It's just something that we will deal with it and not let it be a barrier to the care.
Very important point. Don't let your fear that you don't have insurance stop you from your treatment or your surgery, something that's critical, life critical.
Right.
At that point also, you really have to intervene with the insurance company, and you might get into some royal fights with them in order to secure it. But in some ways, you become the patient advocate for their insurance and to keep their insurance going. And I think most of us, if we are in the middle of an interruption, we'll do the rest of it for free.
Wow. Well, I think all of this really shows, you know, your commitment to your patients and, you know, as doctors, you know, wanting to do the best, keeping the protocols at the highest level to keep people as safe as possible during this time, providing telemedicine and phone medicine so that people can stay in touch with their doctors during this time of COVID. And then, you know, really being an advisor in terms of, you know, what treatment is critical and what treatment can wait during this time. So, you know, this has been such incredible information. I think, you know, very, very valuable for people to know and to take seriously, and to consult your doctor and not make a decision just out of fear of COVID. And also keep in mind that this hasn't been years, this has been weeks, and that screenings are going to come back and are available now, and that along with your doctor, you can make the right decision for you to keep you healthy and safe. Is there any other last words that any of you would like to say before we part? I certainly thank you for your time. Really has been generous with your time and
No, thank you for the opportunity. It's been a pleasure.
Yes, thank you very much.
And
Yes, thank you. And I think we are into probably, I think we were all frozen about 6 weeks ago, and I think we're into a slow thaw at this point. I think assuming nothing new happens with the virus, and we don't know what's going to happen with the virus, I assume we're going to get back to normal another 3 or 4 months, or at least close to normal, or whatever the new normal is.
That's certainly a wonderful thing to hear. And still, don't make the decision on your own. Contact your doctor and make sure that the decision that you're making is made with in consulting your doctor and based upon your own cancer and your own needs. But thank you so much to Dr. Gliedman, Dr. Azizi, Dr. Kehoe. I really appreciate your being here with us. To our attendees, thank you so much for spending time with us this afternoon. I hope that this was beneficial to you, and wish you all very safe and happy rest of the day and week. Thanks so much for being here. Bye-bye.